Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. In this episode, we focus on a key community affected by hepatitis B viral infection, older adults. I'm joined today by Dr. Robert Brown, Professor of Medicine and Chief of the Division of Gastroenterology and Hepatology at Weill Cornell Medicine in New York, Dr. Nancy Reau, Professor of Medicine, Chief of the Section of Hepatology, and Associate Director of Solid Organ Transplantation at Rush University Medical Center in Chicago, and Eric, a person living with chronic hepatitis B. They will discuss their solutions to overcoming barriers to HBV care in older adults. To follow along with the accompanying slide set, please visit the link in the show notes for this episode. Now, let's get started and hear what Dr. Brown, Dr. Reau, and Eric have to say about HBV care in older adults.
Thank you so much. I'm really excited to be part of this program. And we're going to discuss some of the definitions and goals of treatment because you really need to know where you're starting and where you need to go in order to define the problem in front of you. So the first thing is that hepatitis B is higher in some of our older populations, and in hepatitis B terms is not the same as what we would hope it would be. And that's a lot of the vaccination program. So children born today are almost universally vaccinated. And as you look at our older populations, that universal vaccine wasn't there. And so our demographics between the age of 30, 40, 50, and greater than 60 show that this population does have hepatitis B. They are having newly diagnosed hepatitis B. So greater than 75% of all diagnosed hepatitis B infections in 2020 were between that demographic of 30 to 59 years of age. The reason that we describe age and hepatitis B a little bit differently than what we might like to is that aging with hepatitis B has histologic impact as we get older. And so what do I mean by that? Most people who are chronically infected with hepatitis B will have their infection for decades. And when you're young, less than 35, the chance of having normal liver test numbers and normal histology is really, really high. As we get older, even if we have persistently normal liver enzymes, which we like to use as a surrogate for less inflammation, less serious disease, we see that from this graphic that when you're between the age of 36 and 50, about a third of our individuals will have significant histologic changes, so scarring in the liver, despite the fact that they have normal or minimally elevated ALT. And as you get older than 50, about half of our individuals will have significant fibrosis, despite the fact of normal liver enzymes. And that's why we start to define age and hepatitis B a little differently, because after the age of 35, you start to have risk for histologic changes. We also recognize that aging with hepatitis B is a little less successful. And what I mean by that is when we look at end points, we would really love to lose E antigen, love to lose surface antigen, love to have immunologic control over the hepatitis B, if not even spontaneous seroconversion. And that's less likely to occur the older that we are. It's also more likely, if it does occur, that it ends in scarring in the liver. So that battle between the body and the hepatitis B is ongoing over the years, takes a toll. So if it occurs when you're a younger person, the liver is much healthier after seroconversion. If it takes a while for it to occur, again, the liver is less healthy. And so you can see rates of cirrhosis and rates of E antigen negative hepatitis, which is that immunologic failure, are much higher in our patients that are over the age of 40 than they are in those that are less than 30. We also recognize that durability occurs less as we get older. So even if you make it to one of these great endpoints, the chance that you're going to relapse or have a reactivation of your hepatitis B goes up, both by your age, as well as how long you might have been treated on an antiviral agent in order to achieve that endpoint. So when we think about advanced liver disease and how we define that, a lot of it is going to be on outcomes. So in an analysis of U.S. veterans, this was a big group of individuals. They found that after the age of 60, there was a 4-fold increase in liver cancer rates compared to those under the age of 40. This drives some of the recommendations on liver cancer screening. Also, in a large cohort in Spain, it showed that those who presented later to care were often older and they presented with more advanced disease. And in the Saudi Arabian cohort showed that the mean age of the population with hepatitis B increased from 2010 to 2015. And that included the proportion that had cirrhosis and liver cancer. So if you don't know you have a disease, you tend to be identified when you have complications, and that occurs more likely as we age. So one of the difficulties with hepatitis B is it integrates into the host DNA. And the longer the hepatitis is active, the more integration occurs. And then if we suppress the hepatitis B with an antiviral therapy, it is less likely to integrate. And some of that integration actually regresses a little bit. So again, it's one of the reasons that we're starting to change the needle on when we consider our initiating treatment and how we monitor our patients who have active hepatitis B. All right, so we're going to open with some discussion, and I'll ask Dr. Brown and Eric, what would you think, given this data, would define an older adult when it comes to hepatitis B?
Well, I think it's important. I mean, there are two components. One is age per se, and the second is duration of infection. When we think of hepatitis C, fatty liver, alcohol-related liver injury, those start in your teens, in your 20s, in your 30s. And so by age 30, you've had disease for less than a decade. Whereas for most patients with hepatitis B, by the time they get to 30, they've had 30 years of disease, more or less. And so they're not old by any stretch of the imagination. They're still quite young. But duration of disease is always longer in perinatal transmitted disease than it is in adult acquired disease.
Yeah, I tend to agree with Dr. Brown that older adults, when it comes to HBV, is probably starting in the late 30s and 40s rather than what we think of old when it comes to adults. And it's exactly for the reason that Dr. Brown cited. And that is, you've been, most of those with HBV, like myself, have probably had it my whole entire life.
And that makes it for a challenge. Is probably when you were diagnosed, you were young, you felt great, you had no symptoms. And so, trying to figure out that you may have something that's going to cause a problem in the next 10 to 20 years, it's hard to fathom. And then by the time you're 50 or 60, it may be too late to intervene and change outcomes. So what did you feel like when you were diagnosed? Were you ready to jump on treatment?
No, not at all. I mean, I actually was not diagnosed until I was 16 years old. And prior to that, I thought I had been properly vaccinated through a series of 3 shots, I think when I was around 12 or 13. But I didn't actually find out until 4 or 5 years later that, one, the vaccination didn't work, and most likely it was because I had already been infected much earlier than that. So it was definitely a surprise.
Eric, I think that you were screened, and that might be unusual in someone who thinks that they were vaccinated. I also think that in a family where they know hepatitis B is in that family, the children and the first degree family members, the close contacts, are more likely to be screened. But it's really in the group of individuals that don't know that Hep B history that we are missing. And I think one of the questions here is really important. And from a patient perspective, what barriers do you think exist if your family doctor says to you, hey, listen, I think you should be screened for hepatitis B. CDC now recommends near universal screening. Let's do this test. And I don't think that occurs very well.
Right. I think certain barriers that I felt like may exist even today, and for me personally, was just not well understood disease. And so there are certain populations that seem to have a high prevalence of, I guess, what they call hepatitis B carriers that aren't infectious. And hence, there are a lot of adults that seem to believe that they've lived with it their whole entire lives. And so and they're still healthy. And so why do they need to be screening, when this is such a common disease? That's one big reason for certain populations. And I think personally, I feel like it might be that a lot of primary care physicians just seems to not understand HBV very well. And so the importance of pushing screening in even their adult patients don't seem to be understood. And as a result, I feel like that could potentially be a big barrier today.
So, Bob, I know that I was talking recently to one of my OBGYNs, and they're really good at doing screening during pregnancy, but our gynecologists are often a primary care physician for a lot of women. And they don't do things like screening for hepatitis B in an older population of women who may not have been screened before. And part of it might be that because in gynecology, they are not aware of some of the same recommendations that primary care or family practice is. Although I agree with Eric, I think our primary care providers still, probably don't understand the importance of screening in a population that they don't think has an infection. But I think our gynecologists are even struggling further. Bob, in your referral group, what are you thinking some of the barriers are? Or maybe everyone in New York is screening at really high rate?
No. I think part of the problem was historically our screening recommendations were complex. You had to ask the patient where they were born, where their parents were born, which felt intrusive and more like racial profiling. And then there was a sense that, well, is it my job to screen or is it somebody else's job to screen? And I think that moving to universal screening is a good thing. I think that this should rest mainly with the primary care provider, though I think if all of us took the time to make sure that people got screened, it would be good. In general, if we're not finding people till they're older, we've sort of failed because since most of this disease is, perinatally transmitted, we want to find people in their teens and 20s at the latest, not in their 50s and 60s, by which point we haven't been doing appropriate care or intervention. And I think that older individuals are usually more amenable to treatment, but earlier treatment is how we're going to change long-term clinical outcomes.
So, Eric, I'm going to build on that. So our third bullet point is really barriers that, make treatment goals difficult. You said that someone who's chronically infected and feels well might not actually think of hepatitis B as an illness per se. How would you approach someone who needs to be linked to treatment that really doesn't think that they need therapy?
I think education is key. When I was younger, I was kind of in that class of I'm healthy, I'm young, this hasn't been affecting me, I feel no different. But as I learned more about HBV, being infected myself, I realized that like a lot of the consequences of this virus comes with time, and as we talked about earlier. And so in doing more research and looking more into HBV, I discovered that a lot of those individuals that I've known personally, as well as just not, heard various stories through, their experience with liver cirrhosis or liver cancer come always at a slightly later age, in their late 40s or early 50s. And it is a result of the virus, attacking their bodies over the decades that they've been carrying this disease, and not so much an overnight phenomenon. And so that's why I feel like if younger patients whom have been identified to have HBV are properly informed, they would understand the importance of treatment. I think that's one of the greatest barriers. I mean, I think there's also other barriers that we can talk about, such as like stigma or cost of being monitored and treated. Those aren't inconsequential financial burdens as well.
Well, I do want to get towards treatment, but I think that that's very insightful. And it sounds like maybe the patient voice to another patient is as important, if not more important, than just hearing your physician say that you need to undergo treatment.
Mm-hmm. Yes. I think hearing stories of people whom, like myself, have felt very healthy and hence maybe initially not needing treatment or even just ongoing care and monitoring, for the importance of staying on top of their HBV infection is super helpful and would contribute very positively to HBV treatment goals and outcomes.
I think that, obviously getting rid of the stigma is important, highlighting, what the long-term consequences of no treatment are, and then obviously understanding the benefits of long-term treatment, using more of a chronic disease model than an infectious disease model, because infections, one, are more stigmatizing, and two, give you the sense that treatment may be short-term, and for many patients, treatments are long-term. So why don't we turn our attention to treatment? And we have to start with what our treatment goals are. At the end of the day, what I tell my patients is I want them to die with hepatitis B, not from hepatitis B. If I can get rid of hepatitis B, even better. But as long as I can improve their survival, prevent disease progression, prevent or reduce the risk of cancer, prevent them from transmitting this to their children, and prevent any complications of disease, I'm okay. Just as when we treat someone with high blood pressure, the goal isn't to lower the blood pressure. The lowering of the blood pressure prevents stroke and heart disease. And similarly here, the suppression of hepatitis B DNA or losing E antigen or normalizing ALT and decreasing inflammation, or obviously our optimal goal of surface antigen loss or functional cure, is a means to the end, which is prevent the disease from progressing, prevent the patient from developing cirrhosis, and reduce their risk of developing liver cancer. And obviously also by lowering viral load, reduce the chance of transmitting to their loved ones or their children. So in all of our treatment guidelines, age has always been a factor because age reflects both the risk of advanced fibrosis and, through integration and long-term inflammation, the risk of hepatocellular carcinoma. And all of our guidelines, whether you look at the Asia Pacific, the European, or the US, have used the ALT and the HBV DNA. And what you can see from all of these is, one, they require an elevated ALT at some level and an elevated DNA, usually with a cutoff of either 2,000 or 20,000 international units per ml. I tend to view the cutoff as 2,000 because E antigen negative patients, you need to use the 2,000, and E antigen positive patients will always be above 20,000. So you don't have to worry about that gray zone for the E positive patients, only that gray zone between 2,000 and 20,000 for the E negative patients. And you can see that in all the guidelines, at either an age of 30 or 35 or 40, there are treatment considerations where they recommend either doing a biopsy or thinking about treatment if there's any fibrosis on non-invasive testing, or if they have a family history of either HCC or advanced liver disease. And certainly if someone has extrahepatic manifestations, we're going to treat them. And it's important that in all of these guidelines, the presence of advanced fibrosis or cirrhosis at any age, at any HBV DNA, is a treatment indication. But one thing that we realized as a community was that these complex guidelines were impairing the approach to treatment. And so a group of experts led by Doug Dietrich decided that a simplified regimen, which had really made big advances in hepatitis C treatment, would allow more primary care doctors to approach treatment where many of these patients are in care, and that using age rather than more complex factors would allow more patients to be treated and improve outcome. And so in this algorithm, and you can see the reference here at the bottom, that for surface antigen positive patients, we're going to measure their HBV DNA. You should, of course, also measure their E antigen and E antibody. You need to exclude cirrhosis using non-invasive tests. Biopsy is no longer recommended or required. FIB4, APRI, or elastography. Anyone with cirrhosis and a positive DNA would be treated. And then HCC surveillance is always important, and it's shown in green. And at what age we start, people debate whether it should be age 30 or age 40. You have to decide. But then using this age of 30 for patients who have an HBV DNA above 2,000, you can see now that 20,000 disappears. Anyone E negative or E positive over age 30, you're going to treat. And the only group of patients that you're not going to treat who are over age 30 are those with an HBV DNA under the 2,000. And those patients will be monitored. And the monitoring I tend to do every 6 months in both the treatment and the non-treatment group because the treatment's so good. And we're going to look for E antigen and surface antigen seroconversion. We're going to measure renal function. And we're going to look for progression, whether they're on treatment, because they can have coexisting fatty liver, for example, or certainly if they're not on treatment, using probably FIB4 and APRI once a year and FibroScan or other elastography every other year. And that HCC screening will start when you start treatment, age 30 in this group, with ultrasound and alpha-fetoprotein every 6 months. And in the non-treated group, probably around age 40. Some say age 20 if they're born in Africa. I tend to start early, usually with an annual ultrasound until they're in their 30s or 40s, and then twice annually. Now, once you've made a decision to start treatment, treatment is relatively simple. We have one nucleoside, entecavir, and one nucleotide, tenofovir, which is available in 2 forms. Tenofovir alafenamide, the newer formulation, which is safer for kidneys and bone because of its lower dose, 25 milligrams, and the older formulation, tenofovir difumarate, which is also in the preferred list. It all have a high barrier to resistance. The advantage of entecavir or TAF over tenofovir difumarate is that tenofovir difumarate can affect bone density and renal function. And so in those that are over age 60 or who have a high risk for either renal or bone disease in the future, we should prioritize entecavir or TAF. Deciding between entecavir and TAF is a little more complex. Certainly anyone who has been treated with another nucleoside like lamivudine needs TAF. TAF or TDF are the only ones that can be used in pregnancy, which is an issue in women of childbearing age. But for many patients, either one would be a reasonable choice. So let's go and discuss this again. Given this treatment data, 1 pill once a day, what were the barriers? And Eric, what did you think about when you were deciding whether you were going to go on treatment?
I think the greatest barrier was not knowing how long this would have to go on for. So I jumped on entecavir probably when I was 28 or so. And I held back. Dr. Reau was my hepatologist and still is to this day. But she and I discussed it for many years before I started taking entecavir, because my hesitation was really, honestly, as I said, I didn't know how long I would have to take it for. So I was trying to push it off for as long as I felt comfortable doing it and not putting myself at risk in the long run.
Yeah. So finding that balance between telling people they have to take it forever, which they may then be reluctant to start, or telling they can take it for 5 years and then they may want to start, but come back and tell you every year, when can I stop? How do you find that balance, Nancy?
Yeah, I think that honesty is always the best policy. And I think that's probably what you heard in Eric's discussion, that we assumed that this was going to be a long-term treatment. I still tell my patients, especially my young patients, that in your lifetime, we will find a way to achieve functional or sterilizing cure. But until then, it's important to control the disease and keep your liver healthy. If I have a patient that I need to strong arm a little more, like Eric was very healthy, but sometimes you know that the patient clearly meets treatment guidelines, and if they don't engage in therapy, they're going to progress. And I say that we would never wait until you had kidney failure or you were blind to treat your diabetes. So we want to make sure that we're as proactive, like you said, Bob, this chronic disease model and not an infection. Eric was lucky in that he did have some time to think. He was healthy, and our goal was to maintain liver health. And he, was allowed to have the ability to reconcile that this was a long-term infection that he wanted to control, and we didn't have to push him to make decisions that he wasn't quite ready to make. And I think, Eric, I'll come back to you a little bit, because one of the things you talked about in barriers was monitoring and cost. And I know that you financially have never struggled with paying for your medicine, but we have talked occasionally about switching it to something else. And there are significant financial implications. And that is part of the conversation when I have patients that are hesitant to start treatment.
Right. Yeah, I think just even between entecavir and TAF, right? There are so many complications with our pharmacy and insurance systems. And then between the concept of when these drugs are still in patent versus off patent, the financial implications are difficult to understand. But at the end of the day, you just know that none of these drugs are cheap, especially in the United States. And so, like Dr. Reau said, I've been super fortunate to not have to worry about being able to pay for such treatments. But I think the various programs that some of these drug developers have for the first years of the drug, such as copay cards, have also been a good assistance in encouraging adults like myself to start on these drugs sooner than later.
And certainly, for many drugs, insurance barriers are certain issues. And but part of the way I simplify management is really to try to get down to twice a year, once a year with me, labs and ultrasound, once a year with their primary care doctor, labs and ultrasound. And by minimizing the monitoring as much as is safe to improve compliance, which raises the question of who's responsible at the end of the day. I certainly end up ordering the ultrasounds even for the 6 months when they see the primary. And if I don't order the lab, sometimes I don't get the right ones. And then who's going to do the bone densities as people get older? Is that the responsibility of the hepatologist or the primary care? How do you approach that in your practice, Nancy?
I think that bone density, I usually send a nice letter to my primary care saying that bone screening is indicated. And if the person comes back and they haven't had it done, then I order it. And if it's abnormal, I send it back to the primary care doctor to address. And if they don't do anything, then I usually refer them to endocrinology, or I make another linkage, because I don't have the bandwidth to do primary care in my hepatology clinic. Renal monitoring is a little bit easier because we just do it along with monitoring for the hepatitis B, but I do struggle with the bone health.
So what age do you start at? Has Eric had a bone density yet?
I don't think so. Eric does a lot of weight bearing exercise, so we've assumed his bones are healthy.
Yeah.
Why don't we move on to our ultimate goal, which is HBV elimination and prevention?
So I'm going to be a little bit brief so we can really have more discussion, but we are all aware that the WHO has elimination targets by 2030, not just for hepatitis B, but also for hepatitis C. And for B, this does mean a 90% reduction in new chronic infections and a 65% reduction in mortality. We know there are lots of ways of trying to achieve this, and a lot of that is going to have to be through identification. I think our biggest limitation with hepatitis B isn't always linkage to care. It's finding the person that needs to be linked in the first place. And as we've been discussing, awareness and education is going to be integral to this. So vaccination is also really important. We don't have vaccines that are anti-cancer vaccines for very many things, but hepatitis B is considered a anti-cancer vaccine. And if we can vaccinate more globally, then that is going to be the key to elimination. And when we talk about elimination targets, it's actually Hep B surface antigen prevalence in children that reflect our elimination goals for hepatitis B. As we discussed a little bit, there have been changes in recommendations for screening. So CDC now recommends near universal hepatitis B screening with surface antigen, anti-surface antibody, as well as core antibody, total, not IgM. And they should be doing that at least once in a lifetime, starting after the age of 18. And although we can talk in discussion, I struggle because this is not currently covered by the, our coding. So sometimes we struggle with getting it paid for, but it is universally recommended by the CDC. The ACIP vaccination did also change, now recommending near universal vaccination, so that if you're surface antibody, surface antigen, core antibody negative, you should be vaccinated. And that includes every adult between the age of 19 and 59 and high risk adults over the age of 60, which do include not just the barriers you would think about, but also our diabetics, because they are exposed to a lot more iatrogenic spread and concern for exposure. Delta is another thing that we want to consider, so that when you're looking at someone who has newly identified hepatitis B, you want to look for other shared, viruses, not shared by hepatitis B, but by exposure route. That includes hepatitis C, HIV, and hepatitis Delta. So we try to do all of that at least once. If you are hepatitis Delta antibody positive, you need a PCR or RNA to see if you have co-infection with Delta. And if you do, then we have to manage 2 viruses. If not, then we concentrate on the hepatitis B. And so I'll then open it up for discussion. Elimination. So Eric, this is probably not something that we talked about when you first met, but is this in patient, groups, or when you're talking to your family doctor, are they talking about these elimination efforts?
I feel like I've never had conversations with my primary care doctor about hepatitis elimination process or efforts. And even, so this was an issue when my kids were born. I had to make sure that my wife's OBGYN was aware of the fact that I was positive, and we made sure that the children were all vaccinated when they were first born. But since then, the topic honestly just has not come up at the primary care level. And I think it's important to again, going back to education or building it into some sort of screening process. That's not just a CDC recommendation, but just a simple policy. I think even at the potentially for pre-18 at the pediatrician levels, if someone has not been vaccinated or even screened earlier on under pediatric care, it would be helpful for some sort of not, like I said, not just the CDC recommendation, but just procedure or recommendation to be made for all primary care physicians or pediatricians to screen. And I think, like you guys have been consistently saying, this is a virus that can be eradicated with time and proper effort. We just have to work on educating the world on how it can be achieved.
Thank you for that. Bob, I know that in my practice, most of my patients are adults, and they're usually referred for abnormal liver enzymes, and the general answer is fatty liver disease. So if we're not doing a proactive screening program, like just screening everyone in primary care, how many of your patients that are referred for abnormal liver enzymes have actually been screened for hepatitis B when they get to your office?
Unfortunately, it's a minority, and that's a problem. And some of them inappropriately screened. I think that part of it is that people don't perceive themselves to be at risk, and people don't perceive their children to be at risk. And we see this not just with hepatitis B, we see similar things with HBV, which is another vaccine that prevents cancer. And I think that we want to do better. And I think part of it is removing the stigma, as Eric said, so that people don't worry about testing positive. I think part of it is that the vaccine regimen with 3 doses spread out over 6 months is a bigger challenge than a 1-dose vaccine, or even than the currently available 2-dose vaccines, which are at 0 and 1 month. But I think that it really does, as Eric says, come back to education. We're all at risk. We all should be screened. When I tell people, you're at risk if you travel and you end up sick in another country, do you want to count on the sterilization practices, or do you want to be protected? That often resonates. But we're certainly not right now in our country at the most positive towards vaccines. And, we need to really work back towards that public health model where the only acceptable rate is 0. And the only way we'll get to that acceptable rate is through universal screening and universal vaccination. And I think as universal screening becomes part of the practice, it will be better because we do much better at universal than at selective screening. Everyone age 45 gets a colonoscopy is a lot easier than having to pick and choose which ones. And I hope that as this percolates through the primary care, they'll make sure that they get universal hepatitis screening. And that's what it should be. I screen for immunity to A too, because we're seeing outbreaks of foodborne A, and I think people should be vaccinated for that as well.
Yeah, I agree. And I think it is important to know that the CDC and the vaccine recommendations are relatively new. I'm hoping that they will translate into higher screening rates. And if we do, as inconvenient as it is, like the BPAs or best practice alert, where you get a reminder if you've not done something, these do increase screening. And so hopefully that will translate. I also hope that in the United States that there is more trust in the medical system, which will improve vaccination rates. I think that it is a kind of a crazy time where pretty much anything that we suggest can be perceived from a political angle. And I don't think that healthcare really should be political, although that's not part of our discussion point. Eric, before we go end the program and talk about like the concluding points, any other recommendations from the patient perspective, ways of improving screening, vaccines, community awareness, destigmatizing the disease?
Yeah, I think destigmatization, I think I touched on everything, but I do believe destigmatization is quite critical, especially in treating older adults, because part of it is there's a sense that, because it's a virus, some people might think we did something to catch it. But in reality, I think most of us that have been infected, like you guys have identified, were likely infected at birth, right? And so it's nothing that we've done specifically in our lives that have caused us to be HBV carriers or patients. And so destigmatizing it so that there's nothing to be embarrassed about, and that this is just a part of life. And furthermore, I think education on the fact that HBV is very treatable and can, if properly treated, can allow someone to live a very long, normal life. If patients understand that, they would be much more willing to embrace treatment and allow the doctors to be able to help them live that normal life, which is ultimately what we all desire for.
Excellent. I want to thank Dr. Brown and Eric strongly. I want to leave our listeners with a few take-home points. The first is that older individuals with hepatitis B will often have more advanced disease, and old is defined somewhere between the age of 30 and 40. So we don't want to age with hepatitis B. Barriers to hepatitis B we've really discussed, but they include a lot around awareness, recognition through screening, the unfamiliarity about how age impacts hepatitis B, some of the concomitant complications such as renal and bone disease from some of our therapies, and how that there are treatment choices and goals that are going to change as patients age. Solutions to overcome some of these really are going to center a lot around awareness. Updating their screening and vaccination recommendations were integral, but we have to make sure that translates to awareness. You have to know something changed in order to change your practice pattern. And then making sure that we're monitoring the disease as well as your renal and bone complications and adjusting your treatment appropriately. So that if tenofovir in the form of TDF was a great idea, that may not be a long-term strategy forever.
I'd like to thank Dr. Brown, Dr. Reau, and Eric for that excellent discussion, and thank you to our listeners for joining in. As a reminder, to view the slide set for this podcast and the full program on HBV care in key communities, minimizing barriers and optimizing care on the Clinical Care Options website, click on the links in the show notes for this episode. Other key communities addressed in this program include Asian American people, African immigrant populations, and people with childbearing potential and their infants. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.